everybody switches off their mobile phones until after the end of the meeting. Thank you. Just so that we can use the time effectively, really. So we'll go straight to the agenda. Welcome and introductions. Can I just check first of all on apologies, Paul?
There'll be nothing today, Mike.
Okay, and then we've got some guests here. We've got Kim Crabtree, we've got Tracy Ellis-Shaw, we've got Natalie Ford, Heather Gallagher, you all know she comes every month, Sarah Hemmer, Heather Holden, have I missed anyone? Annette Shepherd. Do you want us to introduce ourselves to you, or are you happy if we just continue with the minutes?
Hi, good morning. It's Natalie, Natalie Ford. It's just myself and Heather this morning. Unfortunately, we do have apologies from Sarah, Kim, and Tracy. But it would be lovely if you'd give us some introductions. That would be really kind of you. Thank you.
Brilliant. Well, I'll go around the room first, and then I'll bring people in on teams. So I'm Mike Thomas. I'm the chair of the trust. Welcome. This way, Paul.
Paul Jones, Company Secretary.
Hi, good morning. Nice to meet you. Phil Woodford, Director of Corporate Affairs.
I'm Alice Bolton, Chief People Officer. Sorry, I'm Bridget Lees, the Chief Nurse. Sorry.
Shane McNicholas, Chief Medical Officer.
Hello, my name's Richard Sachs. I'm the Director of Governance.
Morning, Scott McLean, Chief Operating Officer.
Morning, Adrian Leather, Non-Exec Director.
Hi, I'm Liz Sedgley. I'm one of the non-exec directors. Morning, Sarah Rees, also non-executive director.
Hello, Hugh Reeve, Non-Executive Director.
Morning, folks. You're very welcome. Hello, my name is Aaron Cummins. I'm the Chief Executive here at the Trust.
And Aaron's going to help me call out the names on the screens because I haven't got my glasses on, but we start with Jill. If you call that.
Yeah,
okay.
Jill.
Jill.
Hi, I'm Jill Stannard. I'm one of the non-executive directors.
Chris.
Hello, Chris Adcock. I'm Chief Financial Officer.
Sakthi, welcome.
Good morning. Good morning. I'm Sakthi. I'm one of the advisors to the board. I'm also the Director of Public Health for Lancashire.
Karen Deeney.
Good morning. My name's Karen Deeney. I'm one of the non-executive directors.
Nicola Barnes.
Good morning. I'm Nick Barnes, Trust Board Administrator.
Ben, morning, Ben.
Hi everyone, I'm Ben Maiden, Chair of Staff Side.
Helen.
Helen. Can't see Helen. You there, Helen?
No, mute. And Melissa, I think it is.
Melissa.
I'm Melissa Young, Business Support Assistant to Company Secretary Office.
Okay. Is that everybody? Yeah. Nicola, do you want to just quickly introduce yourself and your colleague? Can you hear me? No, Natalie, sorry.
Sorry, apologies. I thought you were talking to Nicola Barnes. So hello, good morning. My name's Natalie Ford. I'm the Clinical Service Manager for the Integrated Community Care Group, and my colleague Heather.
Hello, I'm Heather Holden. I am a CSP student based at Carnforth District Nurses.
Thank you. And we'll just quickly go through the agenda and then we'll bring you in if that's okay.
Yeah, perfect. Thank you.
Done, apologies. Any declaration of interest? No, thank you. Minutes of the Board of the Directors meeting on the 26th of January. So we want to approve it. It's a correct record. Yeah, thank you. And then the action sheets and matters arising. Paul, anything there, please?
Yeah, thanks. A couple of matters, Mike. So firstly, we've now got an update on pathology, which we'll pick up under the PCB update. We've also got the clinical strategy coming forward on today's agenda. Just one point, just to kind of pick up, we have had on the agenda for a while as an action tracker, kind of updates on staff consultation and engagement. We've had a number of kind of reports which have referenced that, and we've had a challenge from Karen about, well, we still haven't seen that final collaborative report yet. We've had a discussion with Ali and we'll pick that up and we'll take that through to People Committee and bring that through. So with the permission, I'd like to add that back into the action tracker. The other thing then to note that there was an action for Phil to do an update on virtual wards. And if I can ask Phil to say a few words about the actions that were taken on that.
Yeah, around communication, not for me to deliver virtual wards. Yeah, we produced a regional news TV opportunity. Unfortunately, we declined that for various reasons to promote virtual wards. So I'm working with the region director of comms on how we do that across the PCB together. There is a view, which I think, we had a bit of debate last time. The name is unhelpful. It's not a virtual service. It physically doesn't exist. In people's minds, we're competing against the word VR, which is headsets, computer games. It's not unhelpful, but it's not the most helpful. So I think at the moment we've agreed we're going to concentrate on what the story is in terms of the experience and outcomes. And I think we saw at the last board, absolutely excellent example from the patients. You couldn't script it any better in terms of the benefits of staying at home with family and how much better that was for him. So we're looking to use more stories. So that's ongoing, but we are looking to do it right across the PCB, not just in isolation. Thanks, Chair.
Okay.
So thank you, Mike.
Okay, thank you. Then we'll move on to item 217, matters for consideration, the patient's story, and I'll move the floor to the chief nurse. Richard.
Thank you so much. So following on from Bill there, in terms of last month we heard around how supporting people at home and what that felt like, and continuing on that theme in the story, I'm welcoming Natalie and our community teams. And this is again related to how supporting people at home and the benefits of that. So I think it's quite a nice theme for the board from last month, really. So I'm going to hand over to Natalie and Heather. Thank you.
So good morning. I'm going to introduce Heather to give you the journey of the patient. Heather was close to this patient and was involved in the journey, so it felt right that Heather delivered the story on behalf of her team, of a collaborative story. So over to Heather.
Thank you. Good morning, and thanks for giving me this opportunity to talk to you about one of our patients, and Mr. P. So Mr. P's journey was coordinated by the local district nursing team. Through prior experience of patient-centred care, the team recognised the need to involve multi-professional working at an early stage to support this patient's journey. This included services from our local community, primary care, social care and the voluntary sector. Mr. P's story demonstrates well how local services work together. Mr. P was an active gentleman. He lived alone since the death of his mother 10 years ago. Mr. P actually lived in a caravan park, so he wasn't in like a street per se. He just had his neighbours to rely on. He didn't have any family or close friends, but he lived an independent life and participated in local community events. In 2006, he was referred from the primary care sector to the district nurses for care of bilateral leg ulcers. He was seen on and off for recurrence of his leg ulcers till 2021. And during this period, he remained well. Lots of the district nurses would see him in the supermarket, and he was just a happy member of the community. In 2021, Mr. P was again referred to the district nursing clinic. Nurses who knew Mr. P noticed that he was frequently failing to attend appointments or turning up when an appointment had not been arranged. Mr. P agreed to a memory test, and after review by several professionals was diagnosed with vascular dementia. Mr. P chose not to be informed of his diagnosis and continued to attend clinics in a kind of haphazard fashion, so we would know to phone him to remind him, and he came in from time to time. But unfortunately, Mr. P became more greatly affected by his dementia. He had a formal assessment to determine how he was managing with day-to-day life and was found to have decreased spatial awareness and was recommended to stop driving. Mr. P declined to be informed of his dementia diagnosis. When he was advised to stop driving, he did not understand why and just ignored the advice. A decision was made to liaise with local services, and Mr. P's car was subsequently removed. This was a very difficult decision, but was made for Mr. P's protection and in the public's interest. Following the removal of Mr. P's car, he was unable to drive to attend district nursing clinics for wound care or for his food shopping. Without family or close friends, Mr. P attempted to go shopping using local transport. He was able to complete the journey unaided to the shop, but was unable to carry shopping home. District nurses began visiting Mr. P at home for his wound care, and during a visit he confided in the nurses that he hadn't eaten and didn't have any food. The district nurse checked his cupboards and found that there was no food in the property. She went shopping and provided enough food for Mr. P to eat for a couple of days. A referral was made to adult social care and safeguarding to continue this. As an interim measure, we spoke with the GP and obtained a prescription for some supplement drinks to ensure his nutritional needs were met. A local volunteer service, Age UK, was contacted to support Mr. P with shopping. They went to visit him and tried to support him, but he didn't understand why they were visiting him, as he had so many professionals already involved, and he turned them away. His care coordinator went back with Age UK and managed to explain to Mr. P how they would support him until a more permanent solution was found. Further risks were identified during subsequent visits. This necessitated visiting with 2 nurses to minimise future potential risks. An advocate was appointed to represent Mr. P during care planning, as although he could manage to live independently, he lacked insight into his care needs. Mr. P's leg ulcers had healed and he was wearing compression stockings. Professionals worked closely in this period to find the right package of care that would meet Mr. P's health, physical and social needs. Care was sourced through a reablement package that would bridge the gap in care until permanent carers were found. District nurses spent a significant amount of time with carers, teaching them how to wash, moisturise and apply compression stocking to Mr. P's legs. A 6-monthly plan was put in place to monitor his legs, and carers were informed they could contact the district nurses at any time if they had concerns. Agreement was reached with a local pharmacy to place Mr. P's medication in blister packs to enable monitoring, and district nurses were then able to withdraw from their weekly visits, knowing Mr. P's needs were being met. Through the coordinated efforts of community, primary, social and voluntary services, Mr. P still continues to live in his own home. Professionals from many disciplines have worked closely to prevent admission to hospital or residential care. His health outcomes have been maximised while protecting both him and the public from harm. There have been no further acute encounters since this plan was put in place. In total, Mr. P had no less than 149 contacts with health services over a 13-month period. 62 of these encounters were with district nurses who coordinated this difficult period of multidisciplinary work to enable Mr. P to live safely in his own home. Thanks for listening. Are there any questions?
Thank you. Bridget, are you going to coordinate question?
Yes, certainly. Just a comment from me. I don't know for others. I felt quite emotional listening to it. Actually, you know, doing the right thing. Yeah, this gentleman failed, but absolutely in terms of the outcomes and supporting him, I think it's really important. Why we're here. Happy to coordinate and take questions.
Adrian and Phil, then I'll leave it to you.
Thank you, Chair, and thank you, Natalie, for sharing that experience and the work that you've done and the work that you've led on, you know, within the community with clearly a very vulnerable person. I just think it's remarkable how much care and compassion and concern you've actually displayed in pulling everything together and working in an integrated way. I'm thinking about the future of what we're trying to achieve in terms of an integrated care system. That work across the voluntary, the public, and obviously the health services, including pharmacy. I was really glad to see that they're being included in the mix there as well. My only question really was going to be, how do you maintain the momentum for this partnership approach with the inevitable continued support that individual is going to want and will expect and will require, just to assist us as a trust to ensure that he has the best quality of care and we're avoiding an admission. So I hope that makes sense.
It does.
It's to recognise the great work that you've done, and it's about the momentum, really.
Yeah.
Thank you.
Yeah, so I think there's a few answers to that question. I think certainly from an integrated community care group, we need to strive over the next sort of 12 months to actually publicise some of our services that are available, so that colleagues within UHMB and outside UHMB recognise what our services can do from a monitoring and supporting individuals in the community. So certainly we work very closely with primary care colleagues around MDT working and ensure that there are pathways that patients can self-refer. So we always would discharge a patient with an open self-care pathway back into a district nursing service or back into a long-term conditions service or back into community services through a pathway. Also within that, we provide a lot of education and training for any care agencies that are involved. So from an integrated way through social services, it's recognised that those care agencies are the ones on the ground seeing, observing, monitoring, and are able to, without delay, refer back into those services that Mr. P might need in the future. And as a district nursing service, I have to commend our services because we are very good and excellent at coordinating those services. So we have a no closed door policy. So if we do get a referral through and we think actually that's perhaps not our area of expertise, we are the ones that will signpost into the right community services, whether that's voluntary social services or whether that's our own community integrated care, other teams, to ensure that we can make sure services are looked after, patients are looked after in their own homes. I hope that answers your question.
Thanks, Natalie. Chief Exec Aaron also wants to come in on that point.
Only very briefly. So Natalie, Helen, thank you very much for sharing that story. It's an unusual time for NHS and care because we've got lots of change happening, haven't we, with places being established and new leadership and potentially different relationships. So just for the board's awareness, I've been working with Scott and Jane with primary care partners, community partners over the last few months, just to recognise that as places start to get established, there's a potential for a loss of momentum and a lack of prioritisation around that kind of integrated care approach. So as we start to develop our plans for next year, you're going to hear and see more about our intention to create, in the interim, a stronger platform for health providers to come together to make sure that we don't lose the good work that we've been progressing. So we've identified it as a bit of a gap in the kind of the changes that are happening, but we put some processes in place that should strengthen that over the next 12 months at least.
Thank you. I'll go Phil, then Sakthi, and then Karen. Phil.
Yeah, thank you. It's excellent, Natalie. You can see how much people care. I'm probably coming at this from a different angle as somebody who's lost his driving licence in the past for the same visual reason. You know, I'm not convinced that moving the car is the right answer. And I've heard all the safety things, and I'm just wondering whether there was a discussion around getting this gentleman, some mobility so that he could get around and be independent. You can see all the independence things and over 100 contacts. That doesn't sound integrated to me. That sounds really overwhelming for somebody to have over 100 contacts, police, fire, social services. It's immense, and I can't help thinking there's a lot of duplication there still. So probably slightly different to everybody else. And I just wondered how it felt over 100 different contacts for this person.
Yeah, I think you make some points there, Bill, around certainly around the driving, and it wasn't a decision that, you know, anybody wanted to take lightly, and we did involve the police in that interaction around actually, you know, were we doing the right thing, and the GP had conversations. And you're right, from a mobility perspective, alternative mobility solutions certainly could have been looked at with this gentleman. So yeah, I'm not aware that we did involve those services, so that's something to take on board. I think secondly, into your other comment about the 149 contacts, it wouldn't be without recognising that there were points of challenges at the time through his journey to try and coordinate those 149 contacts. For the gentleman, I would like to think that he felt that was quite seamless behind the scenes. So there was the challenges in trying to communicate and making sure we had, you know, the right people at the right time in the right place to help coordinate his care. But it was around making sure that he had one voice. And I think what we did well was recognise that although there were lots of voices behind the scene, for him, he heard one voice around that coordination of his care. I think there was some duplication. We did have to involve colleagues on more than one occasion to try and get some outcome, but it was about keeping that integration, that momentum going for that patient, and just advocating on his behalf, really, that actually we needed to take some actions and we needed to do them quite quickly for him. So yeah, I think I would acknowledge your points there, Phil.
Thanks, Natalie.
Okay, thanks, Natalie. Sakthi, please.
Thanks, Chair. Heather, Natalie, brilliant. I mean, this is every time we listen to someone's story, there's so many angles, and I just want to thank you first. And a couple of perspectives. I mean, Aaron and Phil have already touched on this in terms of not losing the focus on integration in all these busy, bangy things that are going on around us, and the person being at the center, or family being at the center of this. But a couple of things. Did you say this person, Mr. P, had a dementia diagnosis? And I didn't quite hear where mental health services role has been in this. Sorry, can I just add one more thing, which is around the ethics, the angle from ethics about best interest, informing the person of their condition. How did we approach that?
So, yeah, the patient did have a diagnosis of vascular dementia, and he didn't want to be informed of that. Ethically, we cannot impose that on him if he doesn't wish to know. And there would be some query of, had we forced it on him, would it have made him feel worse? He knew he had a memory problem. He knew it was affecting his ability to drive. He knew that he wasn't able to manage as much in his day-to-day life, but giving it a title of vascular dementia would perhaps have been meaningless to him in his context. Yeah, it was very difficult ethically to take his car away, and the presentation was originally far longer, and it has been condensed significantly. And a lot of the information about when police were involved and how many times Mr. P was spoken to about removal of his car and about not driving has been omitted from it, unfortunately, to fit it into the time constraints of today. But there were those encounters and those thoughts there.
And from a mental health involvement, you know, we were working quite closely with his GP in the community and primary care around actually what support he would need. And I think he was, you know, of a view that the memory assessment was appropriate from his diagnosis perspective, and that although we had taken some steps actually from a mental health perspective, he was functioning quite well in terms of his emotional stability once we'd managed to get him to maintain his independence in his own home and put some measures in place that meant that actually he could remain independent and still be actively involved in the community. So I think it wasn't probably at that stage necessary to go down the formal mental health route, but certainly we did involve a lot of our safeguarding colleagues within social services to ensure that we were managing him as safely and proactively as we could from an ethical and a mental health perspective. We did have best interest meetings, etc.
Thanks, Natalie. I think it's worth remembering this is only going to be a declining condition with Mr. P. So at some point this will rear its head again. Thank you.
It will. Thank you.
Okay, I'm conscious of time, colleagues. Heather, you've just reminded us there. We recognise it's a condensed patient story because of the time constraints. I'm sure colleagues in the board, if they want to discuss things in detail, can contact you via Bridget if they wish to pursue further questions. But I'll just take one from Karen, one from Lorraine, and then I'll move on.
Thank you, Chair, and thank you, Natalie and Heather. What, in addition to the points that we've heard, what really struck me in your description is how you were describing and referring to a person as distinct from a patient. That really struck me. And what particularly seems really valuable is your insights and your awareness amongst yourselves and your colleagues about the lives, the challenges, the opportunities of people like Mr. P. And I'm wondering whether we are really taking advantage and maximising all of your insights and thinking and understanding to the more acute side of our services. And so thinking, this is a brilliant story about admission prevention. Are we also bringing all of your insights and learning into our effective safe discharge thinking with a kind of people rather than patients mindset?
Thank you. I value that feedback, Karen. So it's probably opportunistic for me to answer that in that we are currently, as an integrated community care group, piloting for the next 6 weeks. It started on the 20th of February, it ends on the 31st of March, a district nurse liaison role that is actually around safe transfers of care from acute hospital out into community services, and recognising that the patients are at the centre and sharing our knowledge and skills and expertise with our acute colleagues around self-care, education, prevention, and how we put the patient at the centre, and actually around what we can achieve in the community in terms of being a little bit more risk averse and recognising that we can keep people quite safe if we have the right care wrapped around them and tapping into the resources we may have. So we will evaluate that pilot after the 31st of March, and hopefully we will recognise, as an integrated services, as community and acute, that we can have some really valuable input into safe discharges.
I look forward to hearing more about that evaluation. Thank you. Thanks, Natalie.
Thanks, Karen. Lorraine, final point.
My final point, which actually Natalie's just covered, with district liaison service. A long time ago, before I finished nursing, we actually did have a district nursing liaison team, and a lot of the work done by them was actually done in and around, with always the patient in mind, or the client, or the person. I think we forget, actually, and I know for since I've retired, that we do forget, and we do, as hospital people, refer to people as patients. When they are out in the community, they are no longer patients. They are people. They are part of a community. And I think between Heather and Natalie today, I think you've shown excellent, absolutely excellent service given that is now the way forward. And I'm sure that district nursing liaison team will be part of that as well. Thanks very much for today.
Thank you for your feedback. It's very much appreciated. And thank you everyone for your time.
Thank you,
Heather. Thank you, Natalie. Thank you for that. Please come back to us. Keep giving us patient stories. You really give us an insight into the complexity of it all, and the amount of liaison and support that one individual would require, really, to ensure that their quality of life can remain as best as it can under the circumstances. So thank you for that. Thank you very much. Richard, thank you as well. We'll move on. Heather, Natalie, thank you. You can leave the meeting if you wish, or you can stay and observe the rest of the board. It's up to you, but thank you.
Thank you very much.
Thank you. Bye-bye.
Okay,
Thanks,
colleagues, we'll move on to item 218, the chair's report. Just a couple of things I want to bring to your attention. First is item 4 on there. We do remain focused, obviously, on soft 4, but at some point, I think the board will have to start talking around business as usual, a post soft 4 agenda, how we're going to work through soft 3, etc. So just to give you the heads up for that. And the non-executive director recruitment, where we've been joined this morning by Tony Oakham, who's one of our new NEDs. Tony, are you there? Can you hear me?
Yeah, I can.
Welcome.
Hi, Mike.
Welcome to the board, Tony. We will be in touch with you after the board to ensure that we meet face to face and you can meet director colleagues, etc. There'll be a full induction, but thank you for making the time to attend the board this morning. It's good to see you.
Looking forward to working with you. Thanks, Mike.
While we're here, Tony, do you want to spend just 1 minute just explaining your background?
Well, first of all, just a warm welcome to everyone. I'm Tony Oakman. I've worked for 25 years at a corporate board level in both local government and the NHS. I worked as an exec director at Mersey Care NHS Trust for 6.5 years. Love my job. Professional background is social work, and love working with people and teams. My last role was chief executive in the North West Authority. So, but retired, having following a bout of ill health, and admitted into Royal Lancashire Infirmary, which is why I was interested in the role, because I had excellent service there from both the moment I was admitted and right through to the moment I was discharged. So it's a privilege to be on the board and a privilege to work with you all. Thank you, Mike.
Yeah, nice. We'll see you soon, Tony. Thank you.
And
again.
you. Take care.
Okay, I'm happy to take any further questions on the chair's report. No, you're happy to accept it? Great, thank you. We'll move straight on then to the chief exec report, item 219.
Thanks, Chair. So I'm going to start off with a thank you. So I'm just checking. I think this is Bridget's last formal board meeting. which has come round incredibly quickly. But it would be remiss of me not to say a few words just to recognise Bridget's leadership and the contribution that Bridget's made to our improvement journey, and actually some of the outcomes we've heard at boards in recent months from patient stories. A lot of that is down to how Bridget will be quick to say it's done by others, but it's a lot to do with how Bridget's reset our relationship with patients, our quality and safety agenda, and led an exemplary piece of work with the senior nurse leadership team to completely reset how our nurse leadership operates and works to make sure that we're delivering the best possible care we can to patients every day. Bridget's come to us at a time where we really needed that really strong, professional, innovative, passionate focus on quality and safety, particularly as we've progressed with our recovery support programme and improvement journey. And I can say absolutely hand on heart, personally and professionally, we would not be in a position where we know we're going to be going through a process to look at that exit criteria in the way that we are without Bridget's leadership. I've been blown away by your leadership contribution and personal support to me at times. So you're going to leave with our love and best wishes to be the chief nurse at Blackpool Teaching Hospital. They're very lucky to have you. I'm delighted that you're staying in the patch. So just a massive thank you from me personally and on behalf of the board, Bridget. Thank you. Okay, so I've done that bit now, so I didn't make Bridget cry, which I've lost the sweepstake. So we've also completed our Chief Nurse Officer recruitment. So just to let the board know that the arrangements when Bridget leaves us will be for Lynn Wire, who's currently Deputy Chief Nurse, to act up into the role until the appointed candidate arrives. The appointed candidate has verbally accepted. We're just in the realms of completing contracts and checks. Indicative start date will be the 1st of May, but subject to confirmation. So just to let the board know. Thank you, Chair. Just in terms of my Chief Exec's update, I'm not going to go through in a great level of detail because lots of the items in my brief feature with a more substantive opportunity for conversation on the agenda later today. Just to recognise that the national focus now is in two parts. It's around making sure that at the end of this year that the NHS, us included, obviously, are achieving the plans that we set out to achieve at the start of the year, predominantly around no patients waiting longer than 78 weeks in our elective recovery improvements by the end of March, and achieving our financial total that's been agreed with the regional and national teams by the end of March. We are also focused on making sure that the recovery support programme improvement work continues at pace and with momentum, and to pick up on the Chair's point, that we don't breathe out at the end of the year to say we think we've achieved the delivery plans. That is not our approach. So the board will see our progress and also our plans for next year of continuous improvements and continuous focus as we work through the rest of the improvement journey. The second area of focus is about planning for next year. We had the planning guidance just before Christmas Eve, it was 23rd of December it came through. Teams have been working really hard now to distill what that means in practice for us. You know, what gaps have we got around those ambitious targets that have been set? The board will see iterations of that draft plan over the coming weeks, and by the end of March, when we get to that March board, we will sign off and agree what our planned deliverables are for the coming year. Sticking with the national, we've also got two further updates. One is around industrial action, which obviously we've been managing as a trust. And just to give notice to the board for those that might not have seen the news yesterday afternoon and this morning, that the planned industrial action next week by the RCM, which we were going to brief on this afternoon in preparation, has been paused, subject to further discussions nationally. We'll keep the board updated as and when that develops. But we have had notification this week of the junior doctor's intention to take industrial action, potentially for up to 3 days, date to be confirmed. We do know that we need to be given 14 days notice ahead of that. We talked yesterday as a leadership group about our approach to managing previous actions through our incident management team infrastructure. We considered whether that was still the appropriate approach given the scale of potential risk with that particular action. We're going to reintroduce a regular board briefing from the IMT So the board will get a daily update on levels of risk mitigation over the course of that particular period. That is assuming that it goes ahead in the way that has been intimated yesterday. So it's just to give the board oversight of that. The final national update is the COVID-19 public inquiry preparations, now under module 3. So the trust has been engaged up to this point on any preparatory materials and responding to requests. We'll be doing so again, so it's just to let the board know that the next cycle of preparation, that review, is now underway. Paul, as the company secretary, and working with Richard and the team in governance, will be ensuring we provide any information that's required of us. We'll keep the board briefed as to any further kind of dates or processes that feature as part of them. Regionally, a lot of focus that cascades from that national position, particularly on landing year-end and planning for next year. A lot of work within the ICS and the Provider Collaborative Board about setting ourselves up for continuous improvement and focused delivery, very similar to what we're doing here, Chair. So there'll be a leadership development workshop this Friday with senior members from the ICS and the Provider Collaborative to talk about leadership development, roles and responsibilities, to make sure we're greater than the sum of our parts as we're all looking at these very difficult challenges we've got to face. And the Provider Collaborative will be having a session later in March about 23-24, so we can check in, a bit of challenge and reflection on each individual partner's plans, but what are the priorities that we're going to really consider that can only be done if we do them together? And as an early insight, some of the work around elective recovery to hit the trajectory for next year is going to require us delivering elective capacity in a different way. And the financial challenge in the system is significant and likely to put more in the space of the Provider Collaborative and Joint Committee for joint decision making as we look to make some of those changes, but we'll keep the board engaged and briefed as we do. Final piece for me locally was really pleased to be part of LGBTQ+ network session yesterday, where we met with Dr. Michael Brady, who's the national lead on the inclusion framework for LGBTQ+ colleagues. Really insightful session, well led by our network. So it was good to engage and think about, you know, with our desire to be a great place to work, we need to keep real focus and discipline on our equality and diversity agenda. So it's great to hear from that. I'll brief the board at my next Chief Exec's brief, because it was only yesterday, but good. That's it for me, Chair.
Thank you. Questions on the Chief Exec's report? Adrian, please.
Thank you. I've got two questions, two areas. The first is about the COVID-19 and the public inquiry. And I just wondered if you could just confirm, will this be conducted at a system level, i.e. through the ICB going forward? And is the primary outcome, is it about learning and quality improvement, and therefore does it fit in and overlap with our other quality improvement work? So it's about dovetailing this additional improvement work in. Thank you.
Thanks, Adrian. So I'll hand over to Paul, who'll give a view of the process, and I might say a little bit about its dovetailing this.
Yeah, thanks, Aaron. So module 3 is the module within a number of modules that the inquiry is looking at, but it's specifically around the impact on health and social care and the communities that we serve. So as Aaron alluded to, we've had communication which we have now responded to, which wasn't a request for evidence, just some preliminary remarks, if you like, just who we are, what our experiences of the pandemic were, some of the risks that we face, the challenges and the overall impacts. So that's been sent through. We've had an acknowledgement from that. And that's been sent to 450 organisations. So the approach of the inquiry at the moment is to approach individual health organisations. However, NHSI have also set up regional teams, so they are looking at this on the geographical footprint as well. And therefore, we can expect that whilst there'll be the opportunity for individual organisations to participate, that in terms of requests for evidence and submissions as we go forward, we expect that to be collated on a regional footprint with the teams. I think it's the first question.
Just the issue of how well it would align to our own quality and safety improvement journey. I think the structure of an inquiry of that nature doesn't naturally align itself to a continuous improvement narrative. Although we have, as a leadership team, reflected lots of opportunities for learning around infection prevention, operational leadership and management with bed utilisation, some of our estates work, the health and wellbeing agenda for colleagues, COVID clinic. So there's been lots that we've done as an organisation. that have changed as a result of our experience through COVID. Now, I think it might be helpful for us to draw some of that together, either to inform the inquiry or just to be clear as to kind of the driver of change. So as we build the 23-24 delivery plan, it might be helpful for us to just draw some connections as to why these things are changing on that basis. I think it's a really good reflection, Chair, about system learning, because if we think back to peak points within the pandemic, some of the work we had to do around procurement, infection prevention, mutual aid, they were elements that we now see play out within the provider collaborative narrative without the pressure of the COVID pandemic. So if it's okay with you, Chair, I'll ask Paul to pick that up within the group with the PCB to see if there is something we might consider at system level separately.
Thank you.
Okay, thank you.
And if I may, Chair, just with a second question.
Yeah,
sorry, thank you. It was really helpful to see Kevin Lavery's letter, and it really outlined the expectations and that 10-year time horizon, which will obviously we're going to have to go through a refresh every year as part of our business plan, and it was about the business planning processes really. When might we receive, and this perhaps for all to respond to, just the new timetable which will allow us as a board and the committees to consider and develop the plans to actually support the development of the joint forward plan, the 3-year financial frameworks, which we're all going to have to contribute to as a trust to make a contribution to that system level. It just feels like an extra layer which we need to factor in terms of the timescales, that's all.
Yeah, thank you.
We'll take that and get the deadlines because it's not clear at the minute, Adrian, so we just need to make sure we get that set up.
It just feels that there's going to be ramifications for our 12-month plan for the board. Thank you.
To add on that, Adrian, we're going to include in the board chief exec's report every month ICB issues and any PCB related issues as well. So we'll probably put the chief exec and the ICB's paper within our board papers. So we just kept up to date on that issue as well. We'll see how it affects our board business.
Thank you.
Yeah, a reflection on that point, Mike. Obviously, with the board papers this time and in the reference pack, we received an awful lot of stuff from the ICB and from their board, including all of their SPC charts and everything. And you sort of, I mean, I have to say, I started looking at them and thought this is just overwhelming. So the ICB ones, not our own ones.
Yeah.
So I think there's going to be a challenge to us, isn't there, in terms of where where our focus goes, and avoiding trying to do and be abreast of absolutely everything that's going on across the ICB. And I think that's going to be a challenge for us, particularly in the coming year, as we settle down and as we try and accelerate forward out of soft 4 into soft 3. And I think there is a slight danger in getting a bit deflected from what our core purpose is. So I just felt that seeing all the added stuff that came to us today. It's just there's only so much space in one's head. Certainly in mine anyway.
Talk to the ICB because we've got a good comms team that supports the PCB, the Provider Collaborative Board, and they're providing summaries to the Trust Board, who are members of the PCB. So we'll probably ask them for their advice on how we just get summaries and pass them on, and then where there are issues that actually impact on trust business, we'll probably get more information. So
I think it's
that'll settle down.
We'll have to learn as we go, but I think it's just it was a reflection.
Karen, questions for the chief exec?
Thank you. Thanks, Chair. My question is about engagement with colleagues across the trust, and it's great to see the tea and talk sessions and that informal opportunity without an agenda. And perhaps this also goes back to the update at the beginning of today's meeting about having a more holistic, full report around colleague engagement. And I'm just really wondering where your conversations, Aaron, particularly around tea and talk and those brilliant informal opportunities, where they triangulate with the rest of what we're learning around colleague engagement. How does that join up?
So Karen, we've got quite a myriad of opportunities that we've put in place under Phil's leadership. So we have our all colleague briefing once a month. We have our team talk once a month. We also have the regular contact with the buddying arrangements, which you'll be aware of with each care group, with each lead executive and non-executive. We then have tea and talks, some of which are general for all colleagues to drop in. I also do a number of those with care group specific teams who've wanted to take that opportunity. And we coordinate any feedback through a number of routes. So either in connections back to care groups, if we pick up care group specific issues, or thematic issues that inform future colleague briefs or team talks or agenda items for work that the communications team pick up. And then we have a repository. So on any ward or department visits or tea and talk, the trust headquarters it takes a bit of discipline for those colleagues that are doing the connections to feed it in. And then we have the opportunity then to feed back any key issues or risks that feature for, again, programmes of work or areas of escalation, predominantly through places like the Exec Directors Group, which meets every week under our hotspot agenda, or through Trust Management Group if we think there's a theme that's coming through. So there's quite an industry around that informal and formal feedback and how it features within agenda items, programmes of work or escalations at care group level predominantly.
Okay. Thank you. Thanks, Aaron. That's helpful to understand that.
Okay, thank you. Phil?
Yeah, Mike, just to add, thanks, Aaron. Karen, just to let everybody know, there's a piece of work between myself, Workforce, RSP with NHS England, and Patients Experience through Corporate Nursing around an integrated engagement strategy. Just sort of as a common approach and some principles. It's all, I think you've already hit on it, Karen. It's all very well talking to people, but there's a difference between hearing and listening. And I think it's doing with that. And it impacts so much in our recruitment and retention. You know, so it's looking at that life cycle of employees and patients. You know, even an exit from an organisation, there's no reason why that can't be a positive experience if it's handled right. So there's work going on to look at that, and I feel confident, Chair, that July I could come back with June, sorry, with an update on that.
Thank you. Thanks, Phil. Okay, colleagues, can we note and accept the Chief Exec's paper? No, yes, thank you. Move on then, item 220, Head Governor's Update. Lorraine, you've submitted the paper, we've all received it.
Yeah, there was just two little things I wanted to add. First of all, from the Council of Governors, can I thank Bridget for all what she's done since she came to the Trust. And secondly, I think we're on a better footing now from a Council of Governors point of view with more face-to-face meetings. Other than that, just take my report as read, please. Thank you.
Okay, thanks, Lorraine. We'll take questions to you as Head Governor. No, we'll accept your paper then. Thank you as always, Lorraine.
Thank you.
Okay, move on then to Quality and Safety, item 221. We've got the progress report on the CQC improvement plan. This is a paper that summarises the current position and progress on the improvement plans for the must-dos and should-dos.
Thank you, Chair. Thank you very much. So I will take the report as read. I'm on page 55 of 239 of the pack for folk to follow. And there were just 4 points that I wanted to emphasise. So just for a housekeeping perspective, this month is unusual because Quality Assurance Committee falls in the same week as Board of Directors, which means there isn't time to tweak the report between it landing at Quality Assurance Committee and coming here. So this is a replica, if you like. And in view of that, the report says that we were at 88 out of 112 recommendations that were completed. Things move fast in this environment, and it's now 93 out of 112. So I wanted just to mention that to you. Support and review panels remain in place, functioning. Lots of challenge for care group leadership teams across the organisation to bring forward their evidence and then tolerance test that to make sure that it's satisfactory. This edition calls out that there were 11 in total recommendations that are overdue. There's a typo there in that it says December, there's 66. It's not, it's a 6. And that figure is now 8 rather than 11. I am happy to take questions, Chair.
Thank you for that correction. Okay, colleagues, we have the report. It's an update. Jill? Jill, I think you're on mute.
Can you hear me?
Can now, yeah.
Can you? Thank you. I just needed to know about the medicines reconciliation. It's saying it may not meet the target. It's been escalated to the Deputy Chief Exec. So will Chris answer? Do we know what's going to happen? When we were looking at it some while ago in Quality Committee, it appeared that many other trusts don't meet the target. But what are we doing about it, and what are we? It's a big risk for us, it seems. Chris, I see you've got your hand up. Thank you.
Chris, come in.
Yeah, thanks, Chair. It was escalated for us to have a discussion at the performance meetings to make sure that this was on track, and there was a fairly lengthy conversation in last week's performance review, but we did just clarify the arrangements that were already in place for this, which was the completion of the phase 2 business case through IPG, which is our investment priorities group, and then recommendation for approval from there, which will determine the shape and nature of next steps. And we're anticipating, I haven't got the date that is going through the various groups, but it is imminent, and we are certainly anticipating that the process concluded ahead of the end of the financial year.
Thank you.
Chris. Sarah.
Thank you. Just a quick update from me, really. We discussed this at Quality Committee on Monday, and I also attended one of the support review panels with the Medicine Care Group, I think earlier in February. So that was really helpful again to understand the level of scrutiny of progress against recommendations. And actually, Richard and I both held firm on one of them in particular, where we felt that actually we needed the evidence that we didn't just have a plan in place, but that the plan was being followed, and so we'd pushed back on one. So I just wanted to sort of first of all say I think we're doing really well in moving forward through all of those, achieving the must-dos, should-dos, and also from my perspective, having again dipped into a support and review panel, feel assured about the level of scrutiny that's there. And we also just interrogated the examples that we've got in here about the difference that it's making, and just noted that on one level they're about good processes at the moment, and what we'll need going forward is that evidence of embeddedness, which Angela Parfitt spoke to as well, in terms of how this will go forward into business as usual. So I just wanted to add that.
You'll take that as part of our triangulation on assurance. Thank you. Okay, no further questions?
I just think we ought to acknowledge, Chair, that given all the pressures that the Trust has been under over the last 6 weeks to 8 weeks, several of us on the committee were actually anticipating that we were going to be falling quite significantly behind on some of these. And I think the work that's been done alongside all the clinical pressures just needs to be recognised and be thankful for, really, and appreciate.
I think we'll note that, Richard, because one of the issues that we've battled with in the past is pace. So thank you and your colleagues for keeping the pace going on these issues during a difficult winter. Thank you.
About 100 other people rather than me.
Yeah.
Yes, that's the one. Thank you. I will.
Okay, we accept the report and the update. Colleagues, thank you. Heather, I know you're here. Just before we move on to item 221I, maternity safety update, and all of 222, sorry. I've just noticed that we have another colleague who's joined the public meeting, and that's Alison Cole. Alison, can I just check you can hear me?
I can, thank you.
Just to introduce Alison to colleagues, Alison is one of our new associate NEDs. Alison, after the meeting, we will be in touch with you and we'll ensure you get into the induction and introductions and one-to-ones, etc. But do you just want to take this opportunity to just say a few words on your background?
Yes, thank you. I know some of the faces in the room, so hello to those. My name's Alison Cole. I'm one of the Deputy Directors at NHS England in the Nursing and Quality team. And I'm very much looking forward to joining. I will just caveat that with that we're having 1 or 2 HR hiccups more on my end than yours. And I've been in contact with the Trust Secretary, so they will get resolved hopefully sometime soon. Thank you.
Thank you. And thank you for making the time to join the board this morning, Alison. It's appreciated.
Thank you.
Okay, colleagues, we move on then to item 222s 1 to 4. Heather, welcome as usual. Over to you via Bridget. Do you want to say anything first, Bridget?
I know, I know.
Heather, over to you, please.
Thank you, Chairs. The first paper 222I is the maternity update paper. I will take the paper as read, just some key highlights to draw the board's attention to. So following a peak of SIs in December, you'll see that we're back down to the expected level now. You will also note on the perinatal surveillance model that's in the reference pack around issues with the training compliance reporting. So the reason it says to be confirmed is because we've identified a single point of failure. So apologies for that data. We have got the data. I just can't guarantee it's 100% accurate, which is why it's not been included in this month's pack, and that will be resolved by next month. You'll see there's some learning identified in the month to assure the board of our response following any incidents. I'd like to draw the board's attention to our maternity dashboard exemption report. We've been asked by Sam Riley of Making Data Count to actually work with her to further develop our pack to be a national exemplar, and this was following East Kent's investigation that Kirkup undertook. So it's a piece of work that she's working with Kirkup on. So we're quite proud to be asked to be involved in that. And that was following a observational audit of our governance new framework and how embedded it is in the service at the moment. So that's some really nice feedback. CNST year 4 was obviously submitted. Year 1 we're still waiting to hear from NHS Resolution. They have prioritised year 4 submissions, so that means any request for incentives discount to be refunded will be impacted on next financial year, not this financial year. They've also requested further information on our action plan to support the nurse staffing for Safety Action 3, which was part of the year 4 submission. So that will be undertaken today by the deadline. You will see the maternity support programme metrics shows continued progress against the exit criteria. CQC maternity inpatient survey, really good results for us. We were 3rd in the North West region and 15th in the country. A full report will come to quality assurance, but that'll be once we've developed and co-produced the action plan with the Maternity Voices Partnership. The report details we will do an Ockenden revisit on the 10th of February. Obviously that's happened now. Karen, non-exec, was obviously part of a discussion with the regional chief midwife as part of that Ockenden revisit. We received excellent feedback on the day. Unfortunately, we don't receive an official report, so I will not be able to evidence that other than just the conversations we had on the day. Cultural improvement plan is currently being refreshed. We're looking at using some workplace psychology and some cultural diagnostics to help refocus and redefine our cultural improvement plan. That concludes the update paper. I'm happy to take any questions.
Thanks, Heather. It's really good. Thank you. I'll just ask colleagues if they've got any questions. The paper is self. Yeah, I'll go with you, Liz, and then Adrian.
Thanks, Mike. Thanks again, Heather, for that. I'm not sure whether it's because there's that many bits to your report, you know, the various 2s and 3s and 4s and 5s. So apologies if it's not come to it. But one thing that struck me when I was reading it was the great work that Maternity Voices and the survey results, wonderful, really positive. And I think there was a comment in the paper about the people that you were trying to draw into that being part of that. And I was really pleased to see that you were going out to get some very young parents involved and people that don't normally come forward to join these. Because my own experience of this way back when was it was very middle class and it felt like a book club. So, you know, to be avoided at all costs. So thanks for
yes, that. Thank you.
Adrian, then Karen.
Thank you, Chair. really so positive to see the results from that experience survey. That was really good. So thank you for sharing that. My question really, but my comment was really going to be about the cultural improvement work. It feels like you're doing a great deep dive on that and getting into the heart of some really quite challenging issues. You're engaging clearly our Black, Asian and ethnic minority staff and valuing their experiences. And I'd just like to know, particularly that work that you're doing about workplace psychology. I mean, that does sound like a development there. What's the learning and how do we spread this across the trust and how can we apply it to other teams? Thank you.
Let me just check who's answering this. Heather
Yes,
or
I'm looking at Alison.
Alison, do you want to answer it?
Yeah, we're commissioning an occupational psychologist to do a really detailed diagnostic at South Lakes Birthing Centre for us. And I think what this is going to do differently is it's going to look at the behavioural aspects, but it'll also look at why people are behaving in the way that they are, rather than just the fact that they might be behaving in that way. So that's one of the key differences. It's going to involve a range of methodologies. So there'll be a survey based on really evidence-based measures. There will be a leadership clinic that will include some psychometric assessments and some feedback. And there will be observations, so actually on-site observations of day-to-day practice, in addition to a number of focus groups and activities that will happen to ensure that we kind of identify and we hear from as many people as we possibly can in the service. That will all then be built into a detailed diagnostic that comes back to us from a team culture and a leadership culture of behaviours, and that will then enable us to take forward some detailed work programmes in terms of addressing the issues that come from that. So I think it just goes a layer beneath where we've gone previously in terms of some of the diagnostic activity.
May I make a request? Can that come to the people committee when we've got some indications of learning and how we might replicate and grow that out?
Yeah, so one of the things that we will be looking at is the cultural diagnostic tool that will be used is something that we're going to have a demonstration of to see whether it's something that we want to use organisationally, and that can be done at organisation and team level. So we're having that demonstration, and then we'll be bringing that into the culture transformation board for and obviously that will feed into people committee as well.
Thank you.
Is that related to this point, please?
Just a very quick point. Could we perhaps have a development? Well, that's been established and you've decided that you're going to go with that tool. Could we perhaps have a little board development session just to talk about it? Because I think that's really helpful across, when you think back of the issues we've had with teams across the organisation, that'd be really good to understand how we can use that going forward.
Yeah, okay, thank you. Karen?
Thank you, Chair. A couple of questions, or the first one, a comment rather than a correction. I just noted, I think this is a typo, on page 65, refers to the CNST Year 4 compliance as 4 out of 10. And given the fabulous, consistent, brilliant work to achieve 7 out of 10, I think it needs to be accurately recorded. So I think that's just a 4 been duplicated. So it'd be great to update that, please. And the second relates to page 72. It might be good to hear a little bit more about this. So there's clearly been really, really great progress. But just in terms of leadership on the table on page 72, we can see that shift from good towards little in leadership development. And my understanding is this is not because things have got worse, it's much more a reflection of keeping the bar very high and recognising the importance of leadership development, cultural development, in really embedding the improvements. But it would just be good to hear a bit more detail around that. Heather?
If you don't mind, Heather, I'll ask you to come back to another board with more details on that, because I'm conscious of time, Karen. We only have 15 minutes to do the whole of 22 1 to 4.
Yeah, absolutely. Yeah, I agree.
I just wanted to reflect that we actually discussed this at Quality Committee on Monday, and actually I also discussed it separately with the Chief Nurse before Quality Committee on Monday. We got exactly the same answer from both the Chief Nurse and from Heather. So from a triangulation point of view, that was really positive. And just to reflect our understanding, which is that it reflects that in each given month, we can't necessarily make the leadership progress we're looking for because we're working through different priorities. So it will fluctuate over time and it's part of the improvement journey. So I did just want to note that because we have discussed it on Monday.
Well,
Thank
on
you.
that case then,
Thank you.
it's going through the relevant subcommittee, it will allow them to scrutinise it so the board doesn't duplicate the work.
Thank you. And that probably relates to my having to give apologies to Quality Committee on Monday and missing that discussion. So thank you. Yeah, I agree. That's already in train.
Okay, colleagues, I'm going to push you a little bit on time. If there's no further questions on this item, you note the paper and the update. Thank you. And then we'll go to 2222 NHS resolution thematic review. Again, over to you.
Thank you, Chair. So this is a paper showing continued progress against the action plan following NHS resolutions thematic review into early notification cases. You'll remember this is a report we received in March 22. We developed an action plan in August and it was presented to Trust Board in December 22. So this is just an update around our response to that thematic review, and it just provides assurance to Board against progress. And you'll see that most of the actions are either complete or they're continuous actions in terms of assurance audits and training. So the plan is now, if Board is happy for that progress to be monitored via Women's Health Board. Thank you.
That's the proposal. Yeah. Yeah. Carried. Heather, thank you. Okay, 2223 Maternity Voices Partnership Report.
Thank you, Chair. So this is a progress report on CNST Safety Action 4, and it demonstrates and provides assurance for Trust Board around co-production and the work with the MVP, specifically around their equality focus and the co-production that we undertake. I'm happy to take any questions. I think the report is quite self-explanatory to help with time.
You,
Chair, just to note that we discussed the capacity of the MVP chair on Monday, and we were entirely supportive of the fact that Heather and the team are looking at bringing more people in to share that role, particularly given the size of our geography, but also the fact that the women that tend to be involved in this have a whole load of other balls to juggle, including jobs, children, and things. And so I think it's more of a governance role than, as Liz described before, it used to be maybe described it. I couldn't possibly have described it as being like going to a book club, but actually the role now is much more of being involved with governance and of the service, as well as just feedback from patients.
Yeah, thank you, colleagues. Just to really for information, the NEDs who chairs some of our subcommittees have been asked to come in on themes or any agenda points, because it triangulates the assurance. So you will note that more and more of our NED colleagues who chair subcommittees will come in on agenda and say, we've discussed this, it's just an assurance triangulation. So Hugh, thank you for that. Okay, then we accept the contents of the report. Heather, thank you. Over then to 2224. The MBRAC Maternal, Newborn and Infant Clinical Outcome Review Programme.
Yeah, so this is the Embrace report. This is just feeding back information on the confidential inquiry into maternal deaths. So that's maternal deaths up to a year after pregnancy. The data covers 2018 to 2020, for which the UK had 536 deaths. So there is a non-statistical significant increase in maternal deaths across that time period. Thrombosis and thromboembolism is a leading cause of maternal death, and psychiatric and cardiovascular conditions, 30% of maternal deaths. So the Embrace report always comes with recommendations. So you will see that there is a action plan against the recommendations. For us, we are compliant fully with 14 of the recommendations, 3 are partially compliant and 1 non-compliant. And you will see that where there is limited or no assurance around them actions, there's an action plan that's developed in the back in terms of our progress moving forward. So the plan will be to provide another assurance paper in 6 months that we have addressed the 3 partially and the 1 non-compliant recommendation.
That again feeds into our embeddedness processes and policies that we've got. So thank you for that, Heather. Colleagues, happy to accept that report, and then we'll have a 6-month assurance update. Okay, thank you. Heather, thank you. Thank you for your conciseness, and no doubt we shall see you again next month. Thank you very much.
Thank you. Bye.
Please pass our congratulations. She's gone. Pass our congratulations to colleagues, please. We're in that funny position that we're in SOF 4 and we're on a recovery journey. When we get into SOF 3, we'll embed that because the goal is to get SOF 2. At some point when we get to business as usual, we need to have a broad discussion with our comms colleagues about how we start to addressing, you know, where there are good news and progress reports and improvement reports, about how we disseminate that. We've kept very calm about areas of growth because we want it to be embedded in the continuity across the trust. It's something to think about, I think. Okay, on to item 223, Recovery Support Programme, UHMB Improvement Plan. Deputy Chief Exec.
Thanks, Chairman. Just a couple of points that I'd like to make. Firstly, the board will note that the report provides specific assurance in respect of points of uncertainty or where clarification is required about how the assessment of our readiness to exit SOF 4, which has been identified obviously through the exit criteria specification. How these items of uncertainty will be managed. We have been having ongoing conversations through gateway meetings with Region. We have had, we've carried out our own internal exit criteria risk assessment, and paragraph 5 of the report provides an example of that in respect of, for example, the maternity safety support programme. So just where we've sought to clarify and tighten up our preparations. Paragraph 4 of the report specifically references the risks to the programme in respect to the periods of operational pressures and industrial action and the mitigations which were being applied in February to ensure that any slippage or additional risk was mitigated in respect to the requirements of the exit criteria. And of course, you've heard and taken some assurance, for example, on the progress on the CQC should and must do recommendations elsewhere. The paragraph 8 also refers to our internal assessment that the outcome of the independent, well-led developmental review carried out by PwC is that the Trust's improvements in this area are consistent with the expectations and requirements to meet this element of the exit criteria. We will report on this formally along with progress against the Trust's well-led action plan to the board at the end of March. We'll also retest our assumptions both internally and on the basis of feedback and other intelligence received and with our colleagues from the intensive support team and regional colleagues through the gateway process. I'd also just like to draw your attention to the discussion with regional colleagues at the recent gateway review meeting in respect to the process for assessment of our progress against our formal enforcement undertakings. That we have agreed specific consideration within the SOF 4 exit assessment and timetable for those matters. One final point related to the work we're progressing with our integrated care board partners referenced in paragraphs 15 and 16 of the report. We've had a number of very positive meetings with colleagues from the ICB, both in respect to their support for the Trust and its progress towards SOF 4 exit, but also crucially in respect of our SOF 4 to 3 transition arrangements and the shape and form of our improvement priorities and focus, which of course will determine the next phase of our improvement programme. We're working to prepare our information and assurance presentations for the board in preparation for our submissions to the single item system improvement board in April. And that, of course, will include the form and detail of ICB support and oversight arrangements for the next phase of the programme. Thanks, Chair. I'll happy to take any questions.
Just before I bring questions in, I'll just ask the Chief Exec if he wants to add on to the report, please.
Only a very quick update. So colleagues at board will have heard me use this kind of analogy a number of times over the last 6 months, which is treating our continuous improvement work more like a half marathon with a very strong 100-metre start, rather than a 100-metre sprint that we then rush through a finish line and we achieve something. So a lot of the work of the leadership team and the board agendas now will be about answering the question, which is confidence of momentum and sustainability. So what we'll be doing as we prep for the single item system improvement board and any exit criteria satisfaction discussions is a board workshop between now and the final item SIB in mid-April, where we can spend some time as a board really testing. I know at board we get assurance and the subcommittees get assurance every month about the RSP and associated items. I think it's really important that we test each other with quite a bit of challenge on levels of confidence, and could we really tell a story of continuous improvement and a resource pack and a way of working that would give confidence that with a soft 3 to 2 journey is kind of where we're focused. I do need to highlight 2 areas for the board to be aware of, that as we progress now to the discussions around exit criteria being satisfied, we have 2 items that we would need to continue to focus on. You saw in my Chief Exec's report the niche phase 5 update. The draft reports came through, was it yesterday or the day before? We still need to provide some further evidence, some assurance. We need to make sure that that report is reflective of the journey that we've been on. So there's still some work to do in phase 5. And the CQC at the last SIB have also requested us looking at the evidence around the formal notices we've had, the section 31, section 28. So there's still some work to do with other partners. So we want to make sure that we've got everything in the space that we need it to be in, and that the board has the opportunity to really kick the tires on that. So before we go as a leadership team into the regional and national discussions, we can be really confident that we've had that conversation here. So we'll be setting that up over the next few weeks, Chair.
Thank you. And just before I bring you in, Sarah, the note that you put in your paper, Chris, that this paper has to be put in the context of triangulation with the Director of Quality's report, the must and should do's, and that supports what Aaron's just said, really. Sarah, and then Phil.
Thank you. I've got a question relating to criteria 4, which is around safety and quality and investigations for serious incidents. In the reference pack on page 63, we've got a continually deteriorating position around serious incident investigations being overdue since the beginning of August. And I haven't really seen any reference to how we're mitigating against that. We do hear about mortality reviews and what the plan is to get on top of those, but I haven't really heard anything about this. It would be helpful to have an update.
Yeah. Who's going to come in on that one, please? Richard?
I can come in on serious incidents. So yes, it does say that on page 63. Interestingly enough, in the same bundle, you can also see that we're doing the exact reverse with actions from serious incidents that we've already done. And that's probably where our attention has been pulled towards, making sure that stuff that we've already known about has got robust actions beside it. In terms of the SI profile at the moment, yep, not a very good picture, and we do need to do some work around that. And I'm going to be sitting down with my deputy Angela to work out what the profile of that is and whether there's anything key in the incidents that we are declaring that would indicate a trend or a theme. So we do understand that there's a piece of work to do there.
Richard, do you want to come in as well?
Thank you so much. Just in terms of our assurance, we have our weekly operational meetings related to this, where everything's monitored through there. So there's been an increase of 10 that are overdue, but in terms of the length of time, some of those, when we've done the analysis, we've done with external partners, etc. So that there are some, we can absolutely see for each case the clarity of what needs to be done, and there's also robust monitoring arrangement in place, which is where we're seeing the outturn on the rest of the measures, where we're seeing reduction on everything else. But we have got I'm confident in terms of the robust management of that.
So in terms of timeline for when we'll start to see that plan for bringing that down. So I understand that we received, of course, Angela's paper at Quality Committee on Monday about the triangulation between complaints, claims and incidents. So that was really helpful to see, but just to understand, because what we don't want is to see this continuing to deteriorate, even with some assurance or reassurance that we understand what the issues might be.
So there's trajectories set for each element of the we can bring that through Quality Committee next month. The guide, so it's helpful, but it's there.
Okay, thank you. Bill and then Adrian.
And just a bit of a comment and a reminder, Mike. I wanted to just look at paragraph 6, just talk about that, which is section 31 notice of stroke. And it's a piece of paper. What's a section 31? Well, it's where the CQC think there's a threat to life. It's that serious if they don't intervene. And it's about outcomes and the experience of the patient. So yes, we might get that lifted, but how does it feel for patients? And I just wanted to remind of it. We now have one of our units that's had its section 31 lifted. That's probably the best rated in the whole region now, an A rating of SNAP. And it is just a number, but what does it mean? And RLI's got to see. That means that the better they do, less people are unnecessarily dying. There's 20 or 30 people across our region who don't need to die every year from a stroke. There's 300 or 400 that don't need to have a disability, yet they do because of the care in the system. So these improving things, yeah, it's great if we get section 31 lifted, but actually people are getting better care. We know that's evidenced, that's really quite robust around the SNAP. So it's just a reminder, Mike, there's a lot of work, but how it is for patients is improving.
Point, Phil. Behind every statistic, there's a human being.
Yeah, can I just, one final thing? I know it's a big team, Mike, but Chris, Bridget, Jane, Scott, and some predecessors, have got it to where it is. After over 15 years, I've seen many programs at this area, and none of them have made this progress. They've gone backwards. So it's a huge thanks. I think it's excellent.
Look forward to it being embedded.
Yeah, absolutely.
Yeah. Thank you. Okay, thanks, Phil. Good points. Adrian?
Thank you, Chair. My question was going to be about sustaining the momentum towards soft food, being able to deliver that at pace. I note the paragraph 16, the RS&E team, but we had a lot of support from that team, stepping them down. That service is being tapered off. 6 months, that teases up nicely for winter pressures, doesn't it? And I just want to know, can you assure us about the capability and the skills of the team, both within trust and at an ICB level, to be able to sustain our journey towards soft 2? Thank you.
So that is the question, Adrian, and it's where I've probably put most of my attention as the Chief Executive over the last 3 or 4 months, working with Chris and the team on a product which is designed to answer that. So what we've got is 2 pieces of work in train. One, Chris alluded to in his report, which is working with the region and the intensive support team about the residual resources left, where we deploy it, and how do we make sure there's a phased transition over the next 12 months. So whilst the formal national recovery support infrastructure might get reduced over that period, there is an offer then from the ICB, to use their phrase, to be a bit more weight bearing in some of the areas of support that we might need to continue with for 23-24. So when we see the 23-24 plan, some of what will feature in that is that resource capability capacity assurance for the board to kind of check in on as we develop the plans for next year. The second piece of work is very specific to an internal challenge about our program management infrastructure, the way that we're utilising business intelligence and performance infrastructure, what we're doing with the continued development of our quality and governance assurance framework, the introduction of a new continuous quality improvement methodology and resource under the chief nurse. So there's a package of things designed to answer that question. We met as an exec team last week, and some of the execs met on Friday to finalise that. We went through it execs yesterday, so it will feature now in this cycle of business for approval, and then come to board to feature as part of the 23-24 plan. I think what would be helpful, my proposal, Chair, to do the workshop around that deep dive and the challenge on sustainability, if we bring some of those proposals into that space so we can kick the tires on a little bit. I'm really confident, having seen these programmes develop before, that the approach we're taking is going to give us what we need, but it'd be helpful to get the board's oversight and challenge around that. So lots of work going into that, and we're in the position now where I think we can make those proposals. But I'm not sure if Chris wanted to highlight anything further there, Chair. Chris?
It's a process that's underway to put all of the detail into all of the points that Aaron has made, and of course, being able to describe this and provide the assurance is part of the information that we need to bring back to the board ahead of the single item SIB as part of our exit criteria submissions.
Okay, thank you. Good question, Adrian. Thank you very much. Okay, Karen, last point on this item, please.
Thank you. It may be that Aaron's response partially responds to this, but my question really is about the wider trust, workforce engagement, capacity, capability to really sustain and embed all of the improvements through SOF 3 and onwards to 2. And I just wonder where that. So we've heard about systems and processes and frameworks, which is excellent, but where does that triangulate and interconnect with the workforce capability, capacity to systematically embed and sustain that? Where will that part of the story be brought together with this one?
Yeah, Chair, I'd recommend we bring that into the workshop because it's quite a complicated response. Yeah, we can flag that to bring it in for assurance.
Yeah, and it builds on Adrian's point. Yeah, thank you. Okay, colleagues, then we've considered the report. We've made some points. Happy to accept it. Yeah, thank you. We're moving on then to performance and resources 2241, 2242. Chris, you'll be taking us through 2241. I left some guidance this morning with a discussion with Paul that you'll take us through the whole dashboard and then I'll open the floor up to questions rather than do questions on each section. One, I'm trying to manage time. Two, I don't want people digressing if then it's covered in a later report that you give us. And I want us to remain focused on the whole IPR, not digress into single issues. So that's why I've asked you to do that, Chris. So if you could give us the whole report, then I'll open the floor up to questions.
Yes, thank you, Chairman. And actually, in the interest of time, perhaps I suggest we go straight into the presentation of any additional information, context or updates from the executive team. So with your permission, I'd like to start with Bridget and Jane, the Chief Nurse and Chief Medical Officer, in respect to the quality and safety elements. Then we'll go to the Chief Operating Officer for operational performance, the Chief People Officer for the people section, and then I would conclude with the finance elements. So could I hand over to Bridget, please?
First thing to say is that this is robust check and challenge through quality committee. Second to advise board is we said last month that we would be applying target setting through the quality and safety measures, which has been done with the exception of a few, which is we wouldn't set a target in some of the patient safety areas, so that's with purpose related to that. In terms of looking at the actual statistics of it, you'll see that from that most if not all of our measures have been consistent variation, with the exception of consistent failing around our accidents and emergency target, and there's also an advice around our pressure ulcer management. So I think in terms of the things that we've discussed and expectation through the quality committee, there's a correlation we've already touched upon it in terms of the work in the RSP programme in our patient safety section and incident management, which is demonstrating, whilst it's not statistically significant, the correlation between the improvements in the RSP programme and what's seen, so we'll continue to monitor that. I think that in terms of the expectations through the committee, we've been clear this time in terms of related to pressure ulcers and VTE, that the expectation is that we'll be seeing an improvement in the position by March, because we're not necessarily seeing the progress that we would expect. So that's been clear through the quality committee. I think that we continue to see common cause variation for Clostridium difficile. However, we've discussed within the context of the narrative the work that's been undertaken, so we continue to look at that. And just noting the work around mortality and fracture neck edema, which we've monitored through the committee, and you can see that actually that's no longer an outlier. And the last thing that we discussed in the quality committee was around the friends and family test specifically related to accident and emergency. And again, the expectations have been set through the committee for both monitoring and what we would expect to happen with that, given the correlation that's been evident, particularly around pressure ulcers and friends and family tests and patient experience and the pressures in the organisation. Therefore, the expectation is that as we see when the Chief Operating Officer updates us that over time is starting to improve, we would expect those to be in correlation, so that will be monitored through the committee. I have nothing further to add. Thank you, Chair. Jane?
Yeah, just again, we discussed both VT and mortality at some length on Monday in Quality Committee. Our VT position continues to improve slowly, but is improving, and we understand the data much better. We've got a better idea of where our issues are, and the leads are working with the clinical teams to develop solutions.
Hello, Lorraine, I think you've got your, thank you, switched off. Carry on.
Sorry. In terms of mortality, our overall trust mortality continues to be better than and in the expected range for us as a trust against our peers. I reported last month that we'd had some improvement in the fracture neck of femur mortality, but it was early days, but that has been sustained. So we no longer alert on one of the two alerting things, which is the HSMR, but the SHME, which takes a little bit longer because it's updated much less commonly, so it's updated quarterly rather than monthly, has reduced but is not yet out of that red zone. But the fracture neck of femur task and finish group continues to work on those sort of small incremental changes, and we've seen some good quality improvement rather than just improvement in numbers, so around blocks to improve pain relief for patients, etc. We've had one thing that's popped up this month, which we're looking into, which is the acute cerebrovascular disease. It may be a recording issue rather than in real issues. So we will go through the process of checking coding, etc. on that in the first instance. And that's all I need to say.
Thank you. Okay, I won't ask for questions. I'll pass the floor back to you, Chris, and if you could bring in your next executive colleague.
Yeah, Chief Operating Officer, please, Chairman.
Thanks, Chris. So you'll see in the data pack, as was the case last month, that the Q2 SNAP scores, as Phil cited, were an A at Furness and C at RLI. The Q3 data is unvalidated. It will come to us validated in March, so we'll be able to report that at the next board. But I would give the board some positivity around what we think the Q3 validated data will show us. In terms of triangulation with the IPR and the RSP, then we have transitioned from the task and finish approach to stroke into more business as usual arrangements, and I think that's testament to the leadership that Phil cites from the teams in the stroke space for sustaining that improvement. The ongoing excellence in urgent community response at less than 2 hours. We continue in common cause variation to be well in excess of the 70% target in the mid-90s. In diagnostics, you'll note in the pack that there's been a improvement from 3 consecutive points of special cause concern into 2 points of common cause variation. And we've got a high level of confidence of achieving the 2% target by May 23. Cancer, you'll see 5 of the 6 targets in common cause variation. Within that, the 20-day faster diagnostic standard has moved from special cause improvement into common cause variation, but it's worth noting that we've had 11 consecutive months of exceeding the target in that very important target. Likewise, in 2-week waits, we see special cause improvement, which is really positive news for us, and that we're better than the target for 2 consecutive months in 2-week waits for cancer. And one of the most scrutinised cancer targets is the cancer waiting list beyond 62 days. There's an ICS target of fewer than 71 by the end of March, and we've been better than that for the last 2 consecutive months. So again, some good progress in that space. For referral to treatment times, you'll see, and I invite you not to be misled by the series of blue dots you see in the 104, 78, and 52-week graphs. Those are good news, and they're in special cause improvement, but it still means there are many hundreds of patients that we could and should be treating more quickly. I'd assure the board that the 104-week breach that's cited in the report is a patient choice breach, not one because of capacity. It's important the board hear that. 7 to 8 weeks, we continue to state our trajectory is to 0 by the end of March, and there are fewer than 50 patients at this stage that we'll seek to deliver care or treatment to by the end of March. There are some risks in that, but we retain a moderate level of confidence that all things being equal, we'll hit that trajectory. And then finally, you'll see that our outpatient DNA rate moved from special cause into common cause variation, but is at 9% against the 4% target. And that significant piece of work we intend to do as we transition with our outpatient transformation programme will be key to that. Finally, Chair, urgent and emergency care, 4 hours consistently in special cause concern. These data are important, and it'd be fair to say that in January, when we saw 4-hour performance drop to 65% and 12-hour performance deteriorate to 10%, that certainly Jane, Bridget and I were concerned around the quality and safety ramifications of that at the time. Pleased to say that's improved. We saw 70% for 4 hours in January and we're at over 80% in February. Which is by quite a bit the best performance in the ICB and indeed in the region. We think that's driven by reduced attendances, reduced COVID-19 and flu in inpatients, and some improvement in not meeting criteria to reside. So we should do justice to the data point in the pack, but give a reassurance we've seen that improve over January and February in both 4 and 12 hours. We've also seen our ambulance handover metrics, which deteriorated to the lowest in December, and these data improved significantly, and in fact are in special cause improvement for the last 5 weeks up to today. Finally, Chair, in urgent and emergency care, it's worth citing at this point the National Urgent and Emergency Care Recovery Plan. That came out around 4 weeks ago. I would seek to bring it back to either a board subcommittee or the board. There's no letter mandating us to bring it to board, but I would suggest it needs to come with a summary of the plan and a gap analysis either to subcommittee or to the full board in Q1, if that's agreeable.
Just before I go back to Chris, then, because I know we're not taking any questions till all the reports are in, but we'll just take that as a proposal. So the relevant subcommittee would be quality. Yeah. When they do that deep dive, because it struck me the other day, because Region, I was talking to various people, and you're right, you know, they were pointing out how difficult December was. And behind these statistics, there are people, you know, people sitting on chairs because we can't have trolleys, people on trolleys because we haven't got beds. They're there for hours and hours and hours. Without doubt, their condition worsens because of that. So when we do the deep dive, it struck me when I was thinking about it, was in RLI the other day, we had business cases brought forward for ED. I don't know if it was before your time, Scott, but certainly the last 18 months, a series of business cases came forward relating to ED and particularly ambulatory walk-ins in children's services, I think, and medicine. And I'd just like to know where we're up to with that, or whether that has contributed to the lessening of the pressure in A&E, or did it contribute to the increase of the pressure in A&E? Just how successful were those business cases, and whether their productivities increased, value for money, etc. Because I don't think we've kept track on those. And I'd like the quality committee to perhaps visit ED, say thank you to the staff, because my God, they did some brilliant work over the last 2 months. But inevitably, patients have a dreadful experience in some cases. So it'd be nice if a couple of the NEDs could perhaps volunteer to, in the deep dive, to go to ED, speak to the staff there, have a look at what's happened to the ambulatory walking in children's and medicine, and just get an overall pattern. Yeah, we're happy with that, Scott. Thank you. Please, again, pass our thanks on to the teams. I meet them in the corridors. They're rushing about, but they do a brilliant job.
Yeah, they do. Thank you, Chair.
Thank you. Okay, back to you, Chris, please.
And Chief People Officer, thank you, Chairman.
Thank you. So you'll see that the vacancy rate is continuing to increase. The hotspots are just the same as they were last month. And we've now commissioned a piece of work to look specifically at the long-standing medical vacancies, particularly consultants, and where we're reliant on locums. So a structured process that's going to be taken into a strategic cell for sign-off in the coming couple of weeks. There's a deep dive happening now because what we've seen is an increasing number of our international nurses leaving the organisation, particularly those who are leaving within 2 years of service. And the majority of them are actually stating relocation as their reason for leaving. So we're wanting to do a deep dive into that. I'm going to take that into People Committee in March. In terms of some of the other aspects around recruitment, there's an issue that we have around availability of affordable housing for colleagues, and really positive to say that there was a social media post that just with a call out to private landlords to see if they could help, and that resulted in 27 offers of help. So I think what we're seeing there is kind of taking different approaches can often be quite productive. The banking agency fill rate is slightly below target, but we've got the work that's happening across Lancashire and South Cumbria now in terms of a collaborative bank, with one of the stated intentions of that about increasing the fill rates. So that's just out to tender now, so we're progressing with that programme, and obviously we'll monitor the progress of that as and when that moves to fruition. I think it's important to call out value for money and return on investment. So the winter incentive rate, obviously with increased escalation beds, required additional staffing, and the escalation rate of pay for our nursing workforce was increased to the winter incentive rate. Under the pay control group now we'll have a review of the impact of that to make sure it helps inform the escalation and de-escalation criteria for any incentive payment. And then finally, really, in relation to sickness absence, I think it's clear that we've still got some concerns around sickness absence remaining high. There's lots of activities that are in place for colleagues in terms of wellbeing. What we have to now do, I think, is look at the evaluation of that, and again, we'll bring that into People Committee, A, to make sure colleagues are aware of what's available, B, that they're able to access it, and see that those services are actually having return on investment for the impact that it has on the wellbeing of those colleagues. And then the final aspect here is really to make sure that we are looking more holistically at sickness absence data, and there's some work now across the ICB to look at overlaying some of the determinants of health to our sickness rates, so particularly demographic profiles, deprivation, public health data, just to see if we can start to see any triangulation with where our colleagues are off sick and if that aligns with public health information as well. So that piece of work will be happening again. We'll be taking that through People Committee for updates and assurance.
Thank you. Thank you. Chris, back to you. Take it finance is the next one.
Yes, thanks, Chair. So the last of the presentation. So the board will recognise the year-end forecast outturn deficit, which was reported at the end of December, and the period in the pack is up to that point. We've briefed extensively that we would be required to make an application to formally change our year-end forecast to record this deficit position, and this happened. This has happened this month, in fact, in February. So we've separately sought and received the approvals required to make this submission over the last week or so. The position we have submitted is slightly better than the position that's presented in this report. We've submitted an £8.1 million deficit, and this is because we've received some additional income since the report was prepared, and we're anticipating some small additional benefits before the end of the financial year. We've clearly reported that the level of stretch required with this improved forecast means that we have no contingency in the case that our modelling or other assumptions understate rising cost pressures or other unexpected events. But we'll manage this on a live basis, and we'll report transparently on all such issues between now and the end of March. We're continuing to develop our data packs for finance, so that the finance section of the IPR provides some information much like the information presented by the Chief Operating Officer for the operational performance section. We have started to include these packs, and but the data isn't yet sufficient to be able to demonstrate the trends or changing in trends, which I will hope to be able to speak to more substantively in the new financial year. The charts that we have included clearly illustrate the impact of the end of the COVID break-even financial regime and a return towards a more normal financial framework. That does, of course, highlight the financial challenges the Trust has faced for some time. And looking at the in-year financial position, we are short on income because we included a stretch income requirement as part of the system planning submissions. And it appears that our pay and non-pay budgets are underspending. However, of course, that's in the context of expenditure levels that are beyond our recurrent income position. So we will get more into this sort of detail with the new charts, Chair, in the new financial year. And I'll stop there, Chairman, and I'm happy to take any questions.
Okay, thank you. Colleagues, questions on the overall report?
Thanks, Mike. Ali, I was really intrigued by your comment about staff, particularly international staff, leaving from lack of accommodation, and thank you for the answer that you gave, some assurance there about what you're doing with it. But it really resonated listening to the patient story about how important it was that the district nurses lived locally to Mr. P and were embedded in their local community, that they picked up on the fact that he hadn't been into the supermarket. And it got me thinking, as we've been going through the discussions, about how to be going forward to make sure that our staff can live in the community we serve, and how difficult that is in the parts of our patch. And what are we doing about that to highlight that? And is there any work done nationally in other areas where you know, that there's rurality and very, very expensive accommodation and people are down to those areas?
So that work is happening now, and it's a question I asked only last week as well. So there is a lot of work that's happening, particularly with social housing and with local authorities, to see if there is anything that we can do to make sure that we've got some appropriate housing that's affordable for people in the area where they're working. I can't give you the answers because it's very embryonic at this stage, but
you said earlier, sorry to interrupt, you said earlier we go through the people committee, so this is all right if we ask the people committee to take that consideration report back to the board.
And the other thing I was just going to mention is, I don't know whether Phil's team can perhaps start highlighting and pushing this message with our local MPs as well, and get them on board and visible on it. I mean, they are probably very visible, but we need to get them as an ally on this.
It's a great point. The volume of Airbnb in this area strangles, you know, the prices, and really pushes it up. Another local MP here has highlighted that quite strongly. We are in talks, Chair, we have been for a while with one city council, based on another model elsewhere in the country, but all the public sector, and Sarah will be aware of this as well, have put in their land and have become the property developer with the council and built. And most new homes have 30–40% margin on them, so that 30–40% is taken off completely. They're all eco homes, they're much cheaper to run, and those are ring fenced for public sector and key workers. So I think there's some work we could do with direct house builders, carry on speaking to the council.
Thank you. Okay, who we got next? Thank you, please.
Yeah. Chris, I'd like to see some charts. I think it's, I was just checking, it was the first time we'd seen them. I hadn't missed them before. It's probably not the place to look at them in detail. I assume that happens in the finance operations group. I'm a bit confused by some of them because I don't think I understand them, and I think if I don't understand them, it's probably a general issue. So the one that I particularly don't understand is one on page 152 rather, where it's got income and expenditure, and income from patient activities, and then income from non-NHS income, and it shows when it's low on income from patient activities, we get blue dots, And I'm a bit confused by that because I thought we want more income from patient activities, and that would be, and then the one from non-clinical and non-NHS income run rate, when it seems to get a lower minus figure, we get orange dots. So I don't really understand that. Am I missing something in there, or is it something about the labelling of those charts? Or so this is just some feedback, and maybe you can't answer it now, but this is just, as I read it, I got confused.
Chris, I'm not going to ask you to respond to that, if that's okay. If it's okay with you, we can have that discussion.
I don't want
outside
to
the
go
board,
into it
yeah.
detail, but I just wanted to highlight it. That if I'm confused, obviously other people are as well.
These meetings are held in public, though they're not in public meetings. So if board colleagues are having difficulties with reading the data, then it's highly likely a member of the public.
That was my
Yeah.
reason for
So
raising it, Chair.
I think if you could just talk to Chris outside the meeting, say, well, what would make the presentation of the data more understandable? That's fine.
And my other point was, Scott didn't really highlight it, but I'm a bit concerned by will be surprised by the outpatient review data that just seems to be exponentially heading in almost a rocket ship type direction. So we had a month last month where for the first time it did drop, but this month it's gone way up again. So there's been and I think we possibly at some committee, maybe it has already happened, but we need to actually understand that because we've received a report of the quality committee about where you presented it, Scott, about that, how we're doing work to understand what the risks associated with that are, but it is climbing quite significant.
Scott?
So I think so we need to be careful not to spuddle. So it was and remains in special cause concern.
Yeah.
So of course this isn't a line graph, so but you're right, it's gone up. So statement of fact, it's gone up, but I think it was and remains in special cause concern. I also, there was a very detailed paper which we spent a great deal of time on at the quality committee. So and that was within the last 2 months.
Yeah.
So I guess that was something to know what else we need to take.
Well, Scott, that was about the risks that might sit within that, and I don't think I'm spuddling because it's special cause of concern and it's continuing to go up. So it's more. This one's is more how we're going to address the numbers rather than the risk of people sitting in that. It's the numbers are continuing to climb, so that the number of people that are risk are actually going up. So it's that sort of general concern that I have, that maybe we need to understand what's being done to reduce the total numbers there.
So I'm not going to give the board an assurance that there's not a cause and effect narrative here where I'm going to say that we're going to do these 3 things and that's going to come down.
No, I don't expect
this is one of those wicked special cause concern metrics where in a system with small, fragile specialties and wicked issues of demand and capacity, we will have patients past their indicative review date. So I think we can describe the work we're doing. We can give reassurance there's work happening. We can give trajectories for what we think a moderate best case scenario is. That's maybe one bit that's missing. Could I give an assurance that even with a good wind, we'd get back to common cause variation? I don't think that's something that would happen anything quickly, if I'm honest.
Yeah, I'm not looking for that assurance. I'm just expressing it. Not only us facing it, sure. It's a concern.
Yeah, thank you. So just check with you, are you raising a point that supports Hugh's point or a separate point? I'll come back to it then. So I'll let Karen come in and then I'll bring Sarah in. Karen?
Thank you, Chair. My question is for Alison, I think most likely around people, and it may be that this is going to be addressed through the People Committee. And whilst it's excellent to see the level of attendance and engagement with the leadership programme and other programmes, I'm left wondering, how can we be cited on the impact of that leadership engagement on improved outcomes and experiences for patients? So where are we going to see the connectivity between that extensive work with our people and workforce and the difference it makes?
raised the same question, Karen, and I feel like we're preempted. Yeah, so I've asked the same question, and I think what we need to do now is get a group of people together to look at holistic measures that we can use to assess whether it's delivered what it intended to. And I think crucially, it's not just about did it do something within the first couple of months, it's has that been sustained as a change in leadership styles and behaviours. So we'll pick that up and we'll again take that back through people committee. People committee is going to be busy.
Yeah, thank you.
Thank you.
Thanks, Karen. Sarah?
Thank you. It was a finance question, actually. So thanks for the update, Chris. What I just wanted to understand actually is where we sit across the system in terms of the deficit we're forecasting for the end of the year. It was a tough stretch target for all of us. And for some of the other measures, we do have an understanding of how we're performing against others. And although I know we have our target, it would just be helpful to understand that context.
Yeah, good point. Chris, are you in a position to answer that?
Yeah, I won't reel out the positions for the other organisations, but yes, we are within a range, an expected range within a comparable level with our partner organisations, and in fact, the way that the further stretch was allocated was consistent across all and matched to some further income that came in the system as well. So. And we we continue to work collaboratively with all our partners about achieving the system financial position.
If just to support what Sarah says, in the next finance and performance committee, Karen, we just have one table that shows our comparators in the PCB, really how the other trusts are doing.
Yeah.
Yeah. Okay. Thank you. Aaron, you want to come in?
Just the last comment, Chair. So it's really interesting for me to see how we're now using the new IPR. We've had it in amongst us for kind of 6, 7, 8 months now. We've been using it, and the level of discussion and debate on, check and challenge, assurance, triangulation, it's pleasing to see. One of my reflections is we probably need to think more purposefully about where we're pointing our transformation resource. So if I use the past IRD example in particular, absolutely right and proper to escalate a concern based on quality and safety and risk and see kind of where we're at. And Scott's response, absolutely right and proper. We don't have a cause and effect narrative with an action plan here. But what that takes us to then is a transformational step change in the way that service is delivered as a proposal, whether that's a service specification change with commissioners or a transformational kind of operational delivery infrastructure change. So when we bring the 23-24 plans together, there will be a recommendation from the executive team about not only the way and the resource and the capability capacity for transformation, but where we're pointing our attention and why. And it'd be a really good triangulation to draw some reference to our IPR where those themes where we know they're in continuous variation that require the step change, that there should be a cause and effect narrative there. So, well, that's why we're deploying the resources here. So I just wanted to draw that into it. There is an action there that will lead us into something different. But I think when we set the 23-24, particularly the transformation improvement programs, some of that's going to have to be driven for those elements in the IPR that we know won't achieve improvement through anything other than a step change transformation. Just a reflection.
Yeah, thank you. Jill. Take that reflection. Thank you. Can you say Jill? Jill?
Yeah, I just want to say that when I read it and heard Hugh's question, it took me to the clinical strategy, which is very clearly talking about a different way of doing outpatients. And that's what we need to do, because there's no point in keep putting all these people on the list and saying, oh, yeah, they're fine. And because it's not picking up the ones we really need to see. So I thought that was looking like it was going to be addressed in the clinical strategy.
Yes.
Okay, we'll take that as a yes. Jill, the response? Yeah, colleagues, thank you. Okay, and just to build up really on what Aaron says, we are time constrained in the board, and there's a lot of data here, so there will be more workhorse type work to be done in the subcommittees. So we're not forgetting, that special ulcers still remain a concern. There don't seem to be any forward motion in the level that we'd expect. Mortality is still there on our radar, even though there's an improvement there. And CD, of course, C. diff is something again that we're watching because we're off target. So even if today we haven't got the time to go into those. I'm just reminding execs that they're not off our radar really. You know, ulcers, falls, weights, elective and ED, etc. remain a priority. So just to remind colleagues to build up on what you said. Okay, no further questions on those. I think we've got several action points from them as well and some deep dives. Okay, we'll if colleagues are happy, quickly go through the 2242 reports and then we'll stop for a cup of tea and coffee and comfort breaks. So we'll take finance and performance. Just give us an update, please, related to assurance. Karen, finance and performance. I know there were meetings this week. We won't have the minutes, but you'll give verbal updates. Over to you.
Thank you, Chair. Just the report from the January meeting I'll take as read, and just three particular points to make the board aware of. The first relates to the draft operational plan for 23-24. We'll see that on the agenda later today. It's just to highlight that we discussed the draft plan submission in F&P earlier this week. We note that there's still significant work being undertaken to develop that draft plan, both collaboratively across the trust and the system, to ensure that a triangulated approach is in place. And with that ongoing iterative work in mind, we have scheduled F&P committee time for the March committee so that we can undertake a detailed review of that plan prior to it coming to board. The second is just to highlight that the committee have noted the QIA process that we'd asked specifically to be updated on. That policy has been updated, and whilst we're not the approving committee, it was really important to note that and particularly highlight the assurance that brings in the way that it's an intrinsic part of the financial improvement programme. We particularly asked for that to be linked not just with the clinical strategy, but also with the patient experience strategy, making sure that we have the assurance that reflects patient voice. And the third item is really is to do with further work, and it relates to operational performance. Scott's touched on this today, but particularly the significance of us becoming increasingly assured about sustainability and the work that to be undertaken so that we can really understand, articulate and describe the demand on services and how we can be well placed to respond to changing demand, both in an upwards and downwards direction. But we recognise that further work's required in that space. So those are the three key items to update the board on from the meeting earlier this week.
Thanks, Karen. Sarah?
It was a question. I don't know what QIA is.
Oh, sorry, quality impact assessment. Sorry, Sarah.
Thank you, Sarah. Okay, no further questions for Karen? No, thank you. Then we're on quality committee. You?
Yeah, thanks, Chair. We had a meeting on Monday, so unfortunately I haven't got a report from that, but very, very briefly, to advise the board that we are monitoring recommendation 35 from the niche external investigation, which was the one recommendation that we weren't at that time confident that hit level 3. And we're now, an enormous amount of work has been undertaken by, look at Richard to get a nod that we anticipate that certainly by the time we see that again in March, we believe that will have achieved that. We hope that will have achieved that level of the niche criteria of the 5 of them, aren't there, but that's number 3. We talked about the MVB chair, just to reassure and assure the board, I think, that we are looking at pressure ulcers and expect, we hope to see an improvement in that, because most of the actions to actually improve that actually seem to take start in November, December time. So we hope to see in the next couple of months some improvement on that. Fractured neck of femur is, we had a detailed report on that, and the mortality data is going in the right direction, as is a lot of the quality stuff associated with it. There's slow progress on VTE. We had picked up, though, there is some discrepancy around the data, and I've had some discussions outside of our committee about that, and that's been picked up more generally about a process for ensuring that the data, any changes to the way data is collected, not just for VTE, but for other areas, is actually done through a systematic route, so that we don't get these discrepancies appearing in major reports. The bowel screening report we received actually assured us that we are maintaining the service despite the fact there are significant pressures in terms of workloads. I think the team needs to be congratulated on that. And finally, to say that we received our first learning from experience report, which Sarah touched on, triangulates things like concerns, complaints, incidents, patient feedback, and looks for common lessons learned. And it was the first time we've received that report. We provide some feedback on that, but it actually was a really good way of starting to triangulate information from various sources and to look for themes. And there were some key themes that came out that were really positive. So I think that was a very important first step. We'll see that developing in future and becoming more sophisticated. So that's the feedback from Monday, Chair.
Thank you. Thank you very much. Any questions for the quality subcommittee?
It's just on that last point, Hugh, that the learning from experience reports, that might be something that maybe quarterly or 6 monthly with global themes becomes not just a verbal update from the assurance committee, but for the board to take some assurance from it in a composite report.
Yeah. Okay. Thank you. People committee, Adrian.
Chair, the minutes and the actions, the 3H report was provided from the January report to the last board meeting, so we've not had a meeting since then. The only further update is about the revision of the terms of reference, and there's a workshop in hand, working with a range of stakeholders, I think it's fair to say, isn't it, which will inform that and develop the role of the committee and ultimately its contribution to the trust in developing strategic delivery plan.
Right.
It's going to operate in a wider context, isn't it? I think it's fair to say, Alison.
I think we want, there was a recognition, I think, that people committee probably didn't have the right membership, and so the intention initially was to have that workshop with the members of the committee, but it feels like it needs to be expanded to make sure we've got the holistic viewpoints in place.
Thank you.
Okay. Questions to the people committee? No, thank you. And final one, cultural programme board update.
Thank you, Chair. Nothing further to add other than what's contained within the updates, only that we're in a very similar position to the People Committee, obviously with fresh eyes from Ali looking at a reset, in particular, looking at that cause and effect narrative and a dashboard development for key measures of what kind of culture we have, what we're trying to achieve and how you measure whether we're progressing towards that. Particularly like Ali's input, you can see it play out in the South Lakes Birthing Centre about using that evidence base, organisational psychology input, so that's going to feature in the next phase. We had a really good conversation also about a bit of check and challenges to the levels of detail that are coming up through the committee and how that committee takes its assurance on what we're doing next. So I think over the next couple of months, as we look for next year's plans, it'll have a slightly different shape to the culture transformation model. Not dissimilar, I think, to some of the reset that's happening in the people.
Thank you. Any questions to Aaron on that? No. Just information to board colleagues on governance process. The updates we've had from the meetings held this week, the minutes from those will come with the next board papers, so there will be a catch up. And second point, post-April, we're going to change the timetable slightly on the board and subcommittee dates, but that will make the running a lot better when we have subcommittees prepare papers and bring them to the board. So that should improve that system. Okay, colleagues, it's 11:40. Shall we stop for a 10-minute break? Reconvene at 11:50. Okay, thank you.